Thank you very much to Vitaflo for inviting me. And I'm going to talk in 4 different sections. So first of all, I'm going to sort of talk about why this topic is starting to emerge as something we really need to be thinking about right now. So I'm going to talk about the basis for how we've started having concerns about this. That's the European guidelines that has sort of flagged this up, and also the NSPKU survey data. And then I will briefly touch on some audit data that Jenny Cook and Sarah Furman from the adult team at St Thomas's presented in SSIM, and then I'll go on to some informal audit or survey data done a year ago by some Vitaflo dietitians, and it's an informal survey of practice in this area by dietitians across the world, but a very small sample. And then I'll finalise by talking about what was discussed at a day in London last month, focusing purely on postpartum. So the starting points, European guidelines. So what European guidelines talked and confirmed strongly about was Diet for Life. And so as well as people working with PKU, focusing on stopping any kind of cessation or falling off of diet, and then encouraging people to return to diet, we really wanted to think about pivotal points in people's lives where they might accidentally sort of default, and pregnancy could be one of those times, or following pregnancy, becoming a mother, becoming having dependence, if you like. And I think that we've always thought that pregnancy and the dietetic management of PKU during that time does have multi-generational outcomes. So by that I mean intellectual impairment of babies born to PKU mothers who's didn't achieve metabolic control. But actually, if we think about the postpartum period and the dietary management of PKU then we've also got a challenge to meet the best multi-generational outcomes then as well. Okay, so European guidelines are kind of laid down a gauntlet, specifically on the nutritional management postpartum. European guidelines suggest adding very specifically about 15 grams of additional protein to support lactation. But I think we can say that there's not a massive amount of data in this area, so that's what we need to work on. And so the other thing that I can talk in a bit of detail about is the paper that was published after the NSPKU survey was analysed, and I was involved in this a little bit. So just to tell you a bit more about the survey, I may have spoken about it at previous occasions, but it was the biggest survey on living with PKU done in the world ever, independent of any industry funding. And 631 respondents replied over a 9-week period, and just over half of them were adults, and a big percentage of those adults were women, so 300 women actually, so over 18 replied. And the survey was very, very detailed, but we asked people 61 multiple choice questions. Can't believe they all did it. And then there were some free text questions as well. Now, arguably, these free text questions were the most powerful because it was unsolicited responses, and we had those analysed. So what I want to just share with you, actually, is this section on reproductive health that the women responded to, and there were 9 closed questions and 1 open question, so 1 free text question, which is simply what's written there in the purple, which I won't read out. And it was very interesting results. The 300 women over 18 that responded, I should say, were more or less in the 19 to 45 year age bracket, as you'd kind of expect for a relatively young disorder. And the 111 of them had actually given birth, and they generated 77 usable free text responses, and we analysed them using something called inductive thematic analysis. That's where you haven't chosen the themes. We couldn't predict what the themes would be. I thought it might be lots about miscarriages, actually, but it wasn't necessarily. So we used this inductive thematic analysis, and the data software is called NVivo. And 4 themes arose from the free text. I'm not going to talk about the first 2 themes. They were very powerful, but not relevant to this talk. But the second 2 themes were challenges in the postnatal period and support required and information gaps, which is basically starting to tell us that we're not giving our patients very much information about what to expect. And also, they will be served by midwifery, health visitor teams, primary care teams. We're not necessarily giving information to those people, infant feeding specialists, for instance. So that's telling us that we need to give more information. Looking at specifically the postnatal challenges, this was actually quite sad and shocking that 41% of those 111 women said that they'd suffered depression after the birth. And then a third of them said they could not manage their PKU whilst caring for their new baby. And about a fifth said they suffered feelings of anger after the birth. Very worrying, but a very small number of respondents said they were worried they might harm themselves or their baby. And then also mentioned reduced support and input from the metabolic team postnatally. So if we think about it, these women, we do really focus on them whilst they're pregnant or having a preconception diet. We are getting blood swaps from them 2 or 3 times a week. So they're having 2 or 3 interactions a week from us or more. And that contact is more or less, that level of contact is more or less withdrawn at the point of the child being born. So it isn't really that surprising that they feel isolated, but I don't suppose many of us we just thought, oh, well, they'll be enjoying their babies now, we'll leave them alone. At least that's personally what I thought. I had to rethink it. So there's also themes of having to unavoidably stop the diet because they couldn't cope with the diet and the baby, and struggling to breastfeed because they felt they just didn't have enough calories and they weren't sure that the PKU diet was giving them enough calories to do the breastfeeding. So it was difficult to juggle those 2 things. So before I go on to the survey of dietetic practice, I just want to allude to the SSIEM presentation that Jenny Cook made last year in Athens. So Jenny and Sarah had also been thinking about this being opportunistic about supporting people at a point when they could potentially come off diet, and getting their women to think, or asking their women about, what diet were they going to choose after they'd given birth. And they looked at 22 pregnancies, and they looked at the diet choices preconceptually, and then they looked at diet choice 12 months postpartum. And then, so what they found really echoes this idea of really not managing both, or certainly being at risk of coming off diet. So the findings from Sarah and Jenny at St Thomas's were that 13%, only 13%, or only 3 patients of the 22 pregnancies stayed on diet if they had been off diet prior to pregnancy. And then conversely, those who were on diet at the point of conception, 28% of the patients had decided to be off diet afterwards. So I think we can conclude that at the point of having a baby, there is a risk of women coming off diet, and we could be doing something about that perhaps. So then a year ago, a 2-day study event that Vitaflo ran, which was international and specifically about maternal PKU, had a pre-event survey of all participants, and I thought quite interesting to just look at this data. So we asked, I'm just going to focus on the postpartum work, we asked dietitians when they first offer a metabolic clinic appointment after the baby's born. So on the vertical axis is the number of dietitians responding. So we've probably got half or just under half are either not sure or it's after 3 months. We've got, I'm not sure if that's 8.5 or 9, we've got out of 19 people, maybe half of the dietitians offered to see the patient before 3 months. I don't think we asked them about phone contacts or email contacts, but we did then ask what percentage of patients attend this metabolic clinic appointment that the data is, because well, I'm not sure about the rest of you who work with adults, but the DNA rate can be a little higher than you'd like due to busyness or forgetfulness. But in this case, when the new baby is coming along for the first time to the metabolic clinic, many dietitians, so 12 out of the 19 said that they thought 3/4 or 100% of their patients came. So that's fantastic. We asked dietitians, do you specifically or actively encourage the mum to stay on the fee-restricted diet after they've given birth? But actually we've got a quarter of dietitians say, well, either no or they left that blank. So there's a little bit of ambivalence there, I suppose. Looking at breastfeeding and the number of responses, estimating women's intent to breastfeed, we had higher numbers of responses saying that yes, somewhere between 70 and 100% of their women were going to intending to breastfeed. But then the reality is actually more responses are hovering around the 50% when you say what percentage of women do breastfeed their infants. Then we asked specific dietary recommendations for protein during breastfeeding, and a quarter roughly have said no, we don't give any. And then we asked about fee intake during breastfeeding, and do you give specific recommendations? And about a third said no, we don't. And finally, this is a pivotal point in terms of weight management. So in particular in the non-PKU population of women, then there may be specific weight management recommendations given, but in the case of PKU clinics, then about 3/4 of us were saying, no, we do not give any specific recommendations about weight management. So there's quite an interest in that difference of practice. It isn't surprising because it's a relatively new area. Then last month, we had a one-day event focusing on particularly postpartum, and we had multidisciplinary speakers invited as well as metabolic dietitians. So many of you are already aware of what a midwife does. I'm not going to say very much about this, but they have the opportunity to make a rapport with their pregnant patients, and they usually stop the postnatal care at day 10. They do have quite an interest in mental health of their ladies after birth, and they told us that at day 5, baby blues, a hormonal phenomenon, is expected to occur, but should only last 48 hours. So you can imagine as well, if you've had PKU controlled at levels of under your Phe controlled at under 250 or under 300, under 360, what is your Phe doing on day 5? Are you even thinking about it? And then this emotional baby blues hormone phenomenon kicks in. So actually midwives do screen after 48 hours if somebody is still feeling low in mood. They will be screening for PTSD, because it's a recognised phenomenon that post-traumatic stress disorder can actually occur as a result of what happens at delivery. And if there's a positive screen for PTSD, then there are some debriefing mechanisms or interventions that can be put in place, and that's usually done about 6 to 8 weeks post-birth. So it's quite useful to be aware of these interventions that midwives can trigger or make themselves. There are other screening techniques around for postnatal depression, and there's also more interventions in the recent years developed, not with PKU patients in mind, I should say, but around peer support for mental health issues, community-based counselling services and hospital-based services for perinatal mental health issues. I thought all of that was really relevant to our mothers who say they feel isolated, depressed, concerned and unable to cope. The health visitor role continues, segues after the midwives have discharged a patient, and they are very involved in the significance of the baby's development in the first 1,001 days. And what they're hoping to achieve is something called sensitive attuned parenting. And they have a body of evidence that backs up their practice about what promotes this secure attachment and bonding. And obviously, poor mental health of the mother is something that would undermine that. They particularly think about vulnerable groups that may have difficulty accessing these health visitor services. And I did wonder if any of our patients fitted into this category. So that was very interesting, and I think that maybe we start to consider more about the wider MDT that our post-delivery mums are involved with. And then just finalising what was discussed at that day, two of our metabolic colleagues, Jenny, who was in the front, who's had to go, from Dublin, talked informally about sort of deep dives into her patient's phenylalanine tolerance post-delivery, and Louise Robertson, he's still here, talked about her Birmingham experience and the Birmingham patients. So I think it's very difficult to say at this very early stage, but it looked as though the phe tolerance postpartum is possibly around the 50% of the phe tolerance at term. Patients really are wanting guidance about how many exchanges would they be needing, and they would like us to be saying, well, we're going to be planning for you to breastfeed if that's what you want to do. And I think my other points are, in reflection on this, is that Diet for Life means talking before the birth of the baby all about the reality of how you're going to do your diet after delivery, and you will be sort of, I'm told, in a bit of a haze afterwards. Asking for blood spots quite soon after delivery, so I've started to change my practice about this, and I've also involved the partner if possible, because they seem to be very, very interested, and they are very, very invested quite often in the maintaining good control during the pregnancy. So they're very happy to get involved. And then the final thing is I am being a lot stricter with my own patients about putting protein substitute and low protein foods in their hospital bag or in their whatever bag, because there's 4 different places you could give birth now, apparently. So if you have a bag to take wherever you're going, you should take these things, because that is a signal to, the intention to follow through with all of this. Whereas it might say, well, in labour, you won't be drinking protein substitute, so don't worry about it. I say, pack it now. And then the final thing is that obviously at the end of term, the mother's phenylalanine tolerance is quite high, and the use of low protein prescribable foods might be quite low. So what we're going to be looking at is telling mothers, well, a month or so before you deliver, you need to be organising your scripts again. And as Melanie's just alluded to, it's actually a little bit cumbersome administration and not reliable, but these foods need to be dispensed again. So there's some practicalities there to be thinking of, and perhaps we were not giving full advice about that in the past, or at least that's what the survey might suggest. So to conclude, I don't think I'm doing too badly for time. I think metabolic dietitians who work with mums who have PKU have a role in perhaps promoting weight management, promoting breastfeeding for the best baby outcomes, promoting breastfeeding for the best mum outcomes, and then promoting the best mental health outcomes after delivery. And that really is joined into promoting that diet for life for the best long-term outcomes. And then really we're continuing to think about those multi-generational effects of PKU management. So thank you for listening. Thank you very much.